Go ahead.
Thank you. Good evening, everyone. My name is Dr. Prasanta Kumar Nayak. I'm the clinical head and fertility consultant at Oasis Fertility Hospital, Bhubaneswar. So today we'll discuss about another very important aspect of female health, which is directly related to infertility, because it is such a condition that is which starts maybe in the early life, like adolescent or in the younger life, and it continues through the reproductive life, and it not only produces a lot of health menaces, but at the same time it is profoundly associated with infertility, and this health entity is known as endometriosis. So as the name endometriosis tells, that it is a condition, the endometrial gland, that means the tissues, the cells which are found inside the uterine cavity, they are called the endometrium, and they have some glands and stoma, which usually gets shedded at the time of each menstrual cycle. It comes as a flow of blood, and consists of the tissue of endometrium and the blood together. So, but what happens? This endometrial tissue gets deposited somewhere else other than that of the endometrial cavity. That means this is an abnormal deposition of these endometrial glands outside the uterine cavity, such as it goes into the out through the tubes or through different mechanisms of development. It is deposited into the peritoneal cavity in the pelvis. It gets deposited on the ovary. It gets deposited in the intestines or rectum, in the bladder surface, in the on the ureter surface, and most commonly it is also found. Sometimes it is found inside the myometrium of the uterus. So that entity is known as adenomyosis. But typically, endometriosis is a condition. It can also found at some abnormal places or even distant places in the body. Well, when such endometrial glands are deposited here and there, other than the normal uterine cavity, there occurs also cellular changes cyclically as it occurs inside the uterine cavity. And at the end of each menstrual cycle, it starts bleeding, just like the endometrium starts bleeding or gets shedding. So when it occurs inside the peritoneal cavity or on the ovary or any other surface on the abdominal cavity or pelvic cavity, it leads to a lot of irritation, inflammation, and some chemical reactions. So the typical presentation usually found in such situations is dysmenorrhea, or you can say cyclical pain during menstruation. It can be mild, it can be moderate, and it can be severe. Many patients are present to us with severe dysmenorrhea. Very rarely, some patients may not have that much profound symptoms, but majority of the symptoms do come with some kind of dysmenorrhea. But well, this is in general, that is endometriosis. But when we talk about infertility, so usually what happens, infertility is also very well connected to that of the endometriosis, as I already told. And as such, infertility is something emotional roller coaster for the couples. Not only because it involves cycles of hope and despair, it involves financial and physical burden. At the same time, it leads to depression and anxiety when there occurs a treatment failure. So along with that, when such conditions like endometriosis gets involved with infertility, it further increases their pain and sufferings, as you can say. Well, if I'll go through the presentation, and we'll discuss about what is this endometriosis and how it is associated with infertility, how we can treat it, whether we need only medications or any surgery is required, and if at all we are giving the treatment, whether we should treat them with IUI or we need IVF, and also whether it also affects the ovarian reserve, and if at all it occurs in among the young girls or before means they plan for pregnancy, or unmarried ladies, whether we can go for fertility preservation and all. So if you'll see the mechanism of infertility, of subfertility in endometriosis, then you can see that this involves a lot of multifactorial conditions like chronic inflammation. Because of this inflammation and bleeding inside the peritoneal cavity of the pelvis, there occurs a lot of adhesions of the omentum of the peritoneal tissue of the tube to the ovary. So one another they occurs entangled, and these inflammatory mediators leading to all these anatomic distortions, which impacts the oocyte pickup and the migration or the movement of these oocytes or eggs through the tubes, and that leads to damage to the gametes also as a result of oxidative stress. and so a lot of damage and inflammation involved in such situations. So that ultimately the impact is that ovum either it gets damaged or it is not able to go through the tube into the uterine cavity, leading to infertility. So in wholesome we can divide the cause of infertility endometriosis in three things. One is the impaired sperm function, because the sperm cannot reach up to the ampoule of the tube, or impaired follicles, or it is get has some oxidative stress because of this inflammation and all these chemical mediators, or there occurs impaired folliculogenesis, because as I told, the ovarian stroma and the ovarian tissue gets affected, or there occurs adhesions in and around the tubes and ovaries, leading to all these anatomical distortions, hence infertility. So if we come across, or we came to know that what is the cause of infertility in endometriosis, then we should also discuss about the treatment options for infertility in endometriosis. We can either go for ovulation induction, we can go for surgical therapy, we can go for ovarian suppression, or even the adjuvant treatments. And if you will go for ovarian suppression for endometriosis, usually nowadays this is not recommended, that don't go for any kind of ovarian suppression before going for treatment of endometriosis, especially you are going to treat for infertility. If you are just going to treat for symptoms like pain and other symptoms, then suppress the endometrium, because we give some hormones that suppresses the endometrial tissue or endometrial gland, and these are usually estrogen sensitive. And if you are giving anti-estrogen substances, that simultaneously suppresses the ovarian function also. So if she is planning for pregnancy, and if we are giving some kind of suppression, like hormonal suppression like gonadotropin or leuprolide, or sometimes we may give Dianogest. So before or after surgery or before treatment also, that usually alone, that usually suppresses the ovarian function. Hence it is recommended that we should not use any kind of suppression if we are treating endometriosis with infertility. And so also, as we think that it is a kind of inflammation, so in medical language, inflammation means some kind of chemical reactions going on around that leads to pain and discomfort. And usually we use anti-inflammatory substances like NSAIDs and other substances like pentoxifylline. So people have also started using these anti-inflammatory substances, but the results has shown that there is not much benefit in terms of fertility outcome. So these are not much encouraged or recommended. Since estrogen is estrogen dependent, some people have also used some anti-estrogen substances like letrozole, and they have tried to find that whether they can suppress this anti-estrogenic activity by the aromatase inhibitors, then whether it may also benefit in terms of increasing or improving pregnancy rate. But these studies, these hyper research or studies have shown that there is no much benefit even if you are using letrozole to suppress the inflammation. So in infertile women with endometriosis, clinicians should not prescribe pentoxifylline other than other anti-inflammatory drugs or letrozole outside ovulation induction to improve the natural pregnancy rate, and it's a kind of strong recommendation. So if you're coming to the laparoscopic surgery for endometriosis, you must have heard in many surgeons, the gynec surgeons, whenever they find any case of endometriosis, immediately, usually they are tempted for surgery, and it is in the form of laparoscopic surgery or the keyhole surgeries, where we just introduce the scopes inside the peritoneal cavity. We identify the uterus tube and the distorted conditions due to endometriosis, and try to remove the endometriotic glands and tissues and whatever gross pathology is there, try to restore the anatomy, and then I think that it will go to help or it will improve her fertility. But laparoscopic surgery increases viable intrauterine pregnancy for definitely, especially if you are doing for low grade endometriosis, like grade 1 or grade 2 endometriosis. If you are doing laparoscopy, it is going to improve the fertility. Similarly, the clinicians may consider operative laparoscopy for the treatment of endometrioma. That means when the endometriosis gets deposited over the ovary, and which is cycle due to bleeding, there are cysts containing chocolate colored fluid, that is called endometrioma or chocolate cyst. And with its increasing cycle, it size of the endometrioma keeps increasing also. So when we are also treating endometrioma, and sometimes also it improves the fertility rate or the pregnancy rate. Although no compelling evidence exists that operative laparoscopy for Even this disseminated endometriosis improves fertility. Operative laparoscopy may represent a treatment option in symptomatic patients. Mostly those are having severe pain and all, and still they are planning for conceive. Then it will help them in both ways. Else, we should be very much judicious while using laparoscopy, because in most of the conditions, especially in endometrium and all, repeated surgeries removing the cyst wall that decreases the ovarian tissue and the AMH, or the reserve of the ovarian reserve. So though it has been found that immediately after laparoscopic surgery, especially in stage 1 and stage 2 or early stage of endometriosis, has led to 5 to 6 times higher chance to get pregnancy if you are doing IUI, intrauterine insemination, followed by these surgeries. And in infertile women with SRM stage 1 and 2 endometriosis, the clinicians may perform intrauterine insemination with ovarian stimulation instead of expectant management or IUI alone, as it increases pregnancy rate. So always IUI is preferred if you are especially dealing with endometriosis early stages and you are doing a laparoscopic surgery. So although the value of IUI in infertile women with SRM stage 3 and 4, when the staging of the endometriosis is advanced to 3 and 4 stages, but tubal patency is uncertain, the use of IUI with ovarian stimulation could be considered only. But it is a weak recommendation, as the results may not be that profound. And there is no significant reduction in implantation, clinical pregnancy, or live birth rates in women with SRM stage 1 and 2 endometriosis compared to women without endometriosis, but in women with stage 3 and 4 endometriosis, and these rates are reduced. So early stages, the chance of pregnancy is higher, but in advanced stages, the chance of pregnancy is lower if you are going for treatments like surgery followed by ovulation induction. And it has been recommended by the ESHRE in 2022 that if you are going for IVF treatment, especially if you are going for IVF treatment, and it has been found that the number of oocytes and the number of mature oocytes, what we call as M2 oocytes, are reduced significantly in cases of endometrioma or chocolate cyst when we are comparing them with controls. So in ART or IVF cycles performed with infertility associated with endometriosis, especially if tubal function is compromised, there is male factor infertility in case of low EFI and or if other treatments have failed. A specific protocol for ART in women with endometriosis cannot be recommended. Both GnRH agonist protocols can be offered based on patients' and physicians' preferences. So whether we should go for, especially in IVF cycles, to agonist or antagonist cycle, that depends on us. So we can use any kind of stimulation protocols, but yes, the kind of oocytes and the quality of the oocytes, everything, the number of oocytes are reduced with endometriosis. So whenever we are planning a patient for IVF, especially we have seen that many patients with endometriosis come to us for IVF because already they have been treated with medications. They have already given several cycles of IUI, several sittings of operations like laparoscopy, and already we have found their AMH value or ovarian reserve is very low. In such situations, we find that it is a very big challenge for us to go for IVF and give them success. So some people may prefer giving some kind of suppression, medical treatment or pre-treatment before going for IVF. But 3 months of dianogestion pre-treatment prior to IVF versus no pre-treatment has found that there is increased cumulative implantation, clinical pregnancy, and live birth rates by some studies. But the extended administration of gonadotropin agonist, especially the Lifride injection before ART treatment, to improve live birth in fertile women with endometriosis is not recommended. Don't go for any kind of injectables like Lifride. But Dynogest is mentioned. Some studies have shown that it may help, but there is insufficient evidence to recommend that prolonged administration of oral contraceptive pills or progestogens like Dynogest as a pre-treatment to ART to increase live birth rates. And when we come to stage 1 and 2 endometriosis and we want to perform IVF, then whether we should go for surgery. The reviews found no difference in the live birth rate, but reported a lower clinical pregnancy rate and a lower mean number of oocytes retrieved per cycle in women with surgical is treated stage 1 or 2 endometriosis. If you find stage 1 or 2 endometriosis and going for laparoscopy and followed by you are going for IVF, all these results like live birth rate, that means the success rate, actual success is the live birth rate, and also the clinical pregnancy rate, everything is reduced or everything is no difference at least. So you should not overburden them with all these surgical techniques. Clinicians are not recommended to routinely perform surgery prior to ART to improve live birth rates in women with stage 1 and 2 endometriosis, as the potential benefits are not exactly clear. So if you'll see the effect of endometriosis on ovarian reserve, then AMH levels in unilateral endometrioma is lesser than their normal counterpart. So there is a one-sided endometrioma chocolate cyst, the AMH level is already less. And if there is a bilateral endometrioma, it further decreases. Hence, after if you are going for surgery again, already because of the endometrioma, the AMH level or ovarian reserve is very low. Again, you are going for surgery. So that leads to further decrease in the AMH level, means ovarian reserve. So the success rate for IVF also decreases. So if you are planning to go for a surgery for ovarian endometrioma prior to ART, then see that what is the actual status of the endometrioma. A systematic review and meta-analysis also failed to demonstrate a significant beneficial effect of surgery on live birth rate. So it is not required always. Clinicians are not recommended to routinely perform surgery for ovarian endometrioma prior to ART to improve live birth rates, as the current evidence shows no benefit and surgery is likely to have a negative impact on ovarian reserve. So no surgery before IVF, even if you get endometrioma or stage 1 and 2 surgeries. But there are a condition called deep endometriosis or DIE or deep infiltrative endometriosis, where the kind of condition called frozen pelvis is found. The tubes, the ovaries, the pelvic tissues, everything combined together, that forms a single mass, and the anatomy is very much distorted. Even for ovarian oocyte pickup, it becomes difficult because of the presence of bowel and means hydrosalpinx and other pathologies in front of the needle. So the decision to offer surgical excision of deep endometriosis lesions prior to ART should be guided mainly by pain symptoms and patient preference, as its effectiveness on reproductive outcome is uncertain due to lack of randomized studies. So they are still in this such a situation also, whether we go for surgery or not is also not much backed by evidence. But if surgery is not the way, then whether we should go for non-medical management strategies in such situations, like other treatments like Chinese herbs. Many people prefer some alternative medicines. But it has been shown that the herbal medicine and or combined pills treated did not increase the chance of getting pregnant after surgery. And the authors concluded that it is better to conceive straight after surgery, so without going for any kind of pretreatment. And regarding non-medical strategies on infertility, there is no clear evidence that any non-medical interventions for women with endometriosis will be of benefit to increase the chance of pregnancy. No recommendation can be made to support any non-medical intervention like nutrition, Chinese medicine, electrotherapy, acupuncture, physiotherapy, exercise, psychological interventions to increase the fertility in women with endometriosis. The potential benefits and harms are actually unclear. So the last part of my presentation, as I was discussing, that whether there is any scope of fertility preservation in case of endometriosis and infertility. As I already told, that many young ladies and young girls or adolescent girls or women before marriage or are married but not planning pregnancy, such situations as the endometriosis leads to decrease in the AMH or ovarian reserve. Whether these people can go for their fertility preservation in the form of oocyte preservation. Yes, definitely, because especially if there is bilateral endometrioma and they have a risk of premature ovarian insufficiency and lower AMH levels later. So surgical treatment can further impact the ovarian reserve. So such people should be offered the fertility preservation. For them, it is a valid treatment option. And definitely nowadays, all the ART centers or IVF clinics are providing this facility, that these girls or young ladies, they can preserve, they can go for ovum pickup and preserve their oocytes, and they can use these oocytes later for pregnancy purpose. So definitely endometriosis with and fertility preservation in endometriosis is a very good and a valid option for the people who can who think that they need this kind of facilities or treatment options. Well, so this is at the end I must say that endometriosis, and in general, that a condition of pain and distress, and if it is associated with infertility, it is associated, then it leads to a lot of means social psychosocial problems. So to deal with this condition, especially with infertility, we need to follow the guidelines, we need to follow the recommendations, we need to know that what we should do and what we should not do, and accordingly we can give treatment or provide treatment to such people, so that they can get at least the best outcome of their disease, even if they are having that disease, the best outcome in the form of getting a pregnancy or getting a live birth. So thank you very much for your patience listening. And today I was very pinpointedly talking about infertility and endometriosis, and how to deal with in terms of medical. Means either we go for conventional treatment, IVA or IVF. Thank you very much. And if there will be any question, then I will be happy to take those questions and answer. Any questions, please? Yeah, can endometriosis make you more fertile? So as already I have discussed that endometriosis is such a condition, by is such a disease that it decreases or reduces the fertility of the female, and with day by day the endometriosis advances to that upper staging, means from stage 1 it goes to stage 2, stage 3, like this. So simultaneously the fertility is also decreases day by day. So definitely it will not improve, rather it will decrease the fertility. Thank you. Any more question? Well, what is the best fertility treatment for endometriosis? So best fertility treatment, we cannot tell. It's not a single option, because the type of patient, the type of disease, the stage of disease, the age of the patient, and her requirement, everything matters. So the best treatment as such, as I told, for stage 1 or stage 2 patients, we can go for laparoscopy followed by IUI. For advanced stage patients, we can go for IVF. And those patients who have been already treated with medical management IUI, the straight away should go for IVF without wasting time. Because as I told, sooner is better, because as we keep on lingering the process or giving a proper treatment, our ovarian reserve is gradually or very drastically or in a decreasing in a very faster rate. So definitely we should go for IVF if the earlier methods have failed or our disease is advancing. Thank you. Does endometriosis affect egg quality? Yes, definitely, and for sure, the eggs retrieved in a endometriosis patient is usually found to be of a lower quality, and even the number of M2 sites retrieved are lesser to their normal counterparts. So altogether, endometriosis leads to decrease in the number of eggs and the quality of the eggs or the oocytes also. Any more question, please? What happens if endometriosis is not treated? So endometriosis, as I told, it is a hormone responsive and progressive disease condition. It increases or progresses till the age of menopause, and after that it decreases. So when the woman is in the reproductive age group, it gradually increases from stage 1 to stage 2, then stage 3, stage 4, like this. Means from earlier condition to advanced and disseminated endometriosis, or deep infiltrative endometriosis. So definitely endometriosis should be treated on time, and so that we can prevent its progress and further complications or clinical symptoms. Any other question? Thank you very much. I think there are no more questions, and thank you very much for your patience listening. Have a good day.